topic is the radial interventions. I'll admit to being a 16-year card-carrying member of a radial club, so I'm pretty biased. My goal is obviously to provide information that may help on your exam, but also just in your practice to really recognize the relevance and importance of this to your patients. Certainly, I think most graduating fellows are inclined to do radial as a radial first operation, but to whatever extent, I hope this helps. So similarly, in terms of format, I think the questions, it's tricky to do one at a time. I was going to do it a little bit differently, a little bit of an honor system. I found fellows to be quite reliable that way. You know, when we ask the questions, think in your mind what your answer is, and then when we get to the answer, I'll just ask you to raise your hand, you know, if you answered it correctly. So it helps me too to get a sense of how easy or difficult the questions may be. So let's see if I can figure this out. I don't know if there's a pointer here. So disclosures, I consult for these companies. So we'll jump right in. The use of transradial access for PCI in the United States is approximately 10 to 20, 20 to 30, 40 to 50, or 60 to 70. I'm going to think about that and think of what your answer may be. This is pretty straightforward stuff. So this is older data, cath, PCI, large data set, NCDR, 3 million patients from 2007 to 2012. Really to show trends. I show this for a couple of reasons, not to know what the current rate is, but just to show at that point in 2012, it was 16% only radial PCI. It's changed. But just to show that there is some groups that fare even worse in terms of radial access. Those older than 75, those with STEMI, females more so than men, and regionally there's differences with the Northeast being the most likely to provide radial access. This, from that same large data, of course, observational showed no differences in procedural success. More recently, the NCDR published, or it was published from the NCDR, 2016 data, which is still obviously 5 years prior, covering up to 2014, the rate had increased to 25%. For those that work in a VA know the CART system. There's 2018, they published data from the VA CART. From 2009, you can see on the bottom there, it's a busy slide, but 5% radial in 2009 up to about 35% 2015. There was actually a SCI statement just a year ago that showed that about 50% of PCI in the US are transradial. This is not published data though. So maybe raise your hand if you got that right. Okay, I'm not sure how this is going to work, but okay. Seemed like we'll see you. The use of, what about for primary PCI, the radial percentage in the United States? 8 to 10, 15 to 20, 25, 33, 50 plus. You might know this one. So similar publications from NCDR showed that up to about 25% of patients, 1 in 4, were getting transradial in 2016 for STEMI. To put this in perspective, this is the Validate Sweetheart trial, which was not an access trial, but a bivalve versus heparin STEMI trial in Europe. And you can see in the bottom left, I just put this for the numbers, of the 6,000 patients randomized, it was operator discretion, 90+% received transradial access for STEMI. Just to put that in perspective to the United States. It is about 25 to 33%, hopefully changing. Major bleeding post-PCI in ACS patients is associated with higher rates of which of the following? Death, MI, stroke, just death and MI, A and B, or all of the above. So again, this is really not debated. These are associations, of course. This is pooled data from some older ACS trials, which show significant risk of harm if you bleed with your ACS. So 4, 5, 6 times odds ratio of these terrible events. Raise your hand if you said he. Okay. All of the following completed RCTs of transradial versus transfemoral access for ACS met their primary endpoint except Rival, STEMI radial, Rifle, Matrix, Safari, or all of them met their primary endpoint. So this is kind of a soft question for me to really jump into the data and go through it. So this will be a little more didactic, and then we'll see what people think their answers were. So the Rival trial, most of you know, was kind of the initial thing that got TR into the mainstream discussion. 7,000 patients randomized to ACS or STEMI to transradial transfemoral with the primary outcome of Mace, so Mace plus bleeding. And the primary outcome was actually no different. So this was felt as a win for transfemoralists, but it really, if you kind of look into it, it doesn't really pan out that way. The subgroup analysis, which was not pre-specified, so it's just really hypothesis generating, was fascinating in that the STEMI group had a significant reduction in the primary endpoint, and it was really driven by the hardest of endpoints, death. So a 2% absolute risk reduction. Again, not randomized for this, but still intriguing. This led to obviously other trials, prospective randomized trials in the space. STEMI radial, 700 patients in the Czech Republic. Randomized, these are just STEMI patients to transradial transfemoral. Their primary outcome was just bleeding and access, so not surprisingly, especially in this ACS group. There was a massive reduction in that outcome, safety outcome, 80% reduction, highly significant. What about Mace? No statistical difference, but numerical trends towards better outcomes with the radial access. Again, now this is a randomized trial. Combined Mace and NACE, obviously with such a significant bleeding reduction, the NACE outcome was also impressively reduced with the transradial access. So that was a positive trial. We saw that Rival wasn't, so that's likely to be the answer. But what about Rifle? Another trial, 1,000 patients randomized. This is in Italy, high volume, high experience centers, femoral versus radial for really all STEMIs, however sick they were. They had two primary endpoints, a 30-day NACE and a bleeding outcome, which were both statistically significantly reduced and real meaningful absolute reductions, 5 to 8% there. Interestingly, the Mace, which was not a primary outcome, was also statistically less in the radial group. And when you dived into it deeper, it was really driven by the hardest. This is kind of opposite to what we know about stent trials and certain medication trials where the combined endpoints are really driven by MIs or target vessel revascularization. This is a combined that was driven largely by cardiac death, which is pretty remarkable. It was eye-opening. It was a high percentage rates. You can see these rates of 30-day death were high, but they really, as I mentioned, included extremely sick patients. Just to point out, in this trial, all of the bleeding reduction was access site related. So it really was related to the access. The needle really didn't move until the Matrix trial came onto the scene, I would say, at least globally. Complex randomization, as you know, TR versus TF for ACS, with some sub-randomizations for antithrombotic. Two co-primary endpoints, which you should know, a 30-day Mace and NACE outcome. The Mace outcome was actually technically not meeting target. They had a predefined p-value of 0.025. It was 0.03, but a 1.5% absolute risk reduction there. When they added bleeding to the Mace outcome, which is the other co-primary endpoint, it was a 2% reduction, a highly significant 0.009. The number needed to treat of just 50 in terms of a strategy change. A lot of people that kind of are trying to fight this, I think, fight maybe what they know is the right way to treat these patients, lean on the Safari trial as a kind of a counterbalancing trial result, but it really isn't that if you even just scratch the surface. So this was published in, presented at ACC 19. A trial of, again, STEMI patients, TR versus TF. It was really not completed. It was stopped for futility. The designers had predicted a 4% death rate, which was, the patients were way less sick than that. And there was really no reason to continue. The rates were near equivalent after more than half of the enrollment. So they stopped this trial prematurely. It's not really proof that there's not a difference. It's kind of like a type 2 error. And if you look at the face of multiple randomized trials and cumulative observational data, it's pretty weak counter effort. So this is Rival. Again, this is, I don't know if it'll be this blatant, but, completed RCT. So Safari STEMI didn't meet an endpoint, but was not completed. So how many people said A? Might be a little bit less because it went into the knowing what the primary endpoints were. In Rival, the primary outcome for 30-day NACE was not different between treatment groups. However, major bleeding was significantly lower in the group randomized to transradial access. Maybe I'll do this differently since it's a binary answer. Who thinks this is a true statement that major bleeding was significantly lower in the group randomized to transradial access? Raise your hand. Maybe a fourth to a half. And false, we get the non-responder rate too, which is about a half to a third or 2/3. So actually, there was not a difference in bleeding either in Rival, the one trial, but really this speaks to the definitions of these trials. So in Rival, the bleeding outcome was defined as TIMI bleeding, which is extremely high threshold, very, very extreme bleeding events to be counted. You can see that by the rate, 0.5% in an ACS trial is extremely low. And there was no difference if you used the acuity bleeding definition in that trial. You can see the rate difference in how markedly significant reduction there is with the transradial axis. So the definitions are important, but there wasn't technically a bleeding reduction in that trial as well. Moving on to Matrix, a statistically significant benefit in Mace was seen regardless of center proportion of radial PCI, low, intermediate, or high. Is that true? Raise your hand. And what about B, false? I think, yeah, it's kind of worded in a way that leads you to answer the question that way. And there's a little bit of test taking on the real test, so there's nothing wrong with that. Yeah, so the primary endpoints were really only seen to be different in the higher experience centers. So proportion of PCI greater than 80%, which was defined as high. You can see on the right of both those columns, one being NACE, one being Mace, driven really by those centers. So it's an important concept, okay? It doesn't mean that you're a low operator, you don't do it. It just means you try to achieve some expertise such that you can provide these benefits. What about in Rival? Similarly, this is individual operator experience, so more than 146, very random number. But if you looked at the high volume operators, their primary outcome was actually positive in this trial, as you can see on the kind of the top panel of the tree plot there. So this is still this is a false statement. It was not regardless of central proportion of PCI radially. Female ACS patients experience a higher risk of severe bleeding and access site complications compared with male counterparts, but still derive significant reduction in these complications as well as ischemic endpoints. Raise your hand for true. It's pretty, most people, false. Okay, another pretty easy one. So this is one of numerous sub-studies that came from Matrix. This is on sex and outcomes. The complicated slides here, the red is female and the dashed is femoral. And you can really just see that the red dashed line kind of had a higher baseline rate. And there was a greater difference, or still reduction, when you looked at the red solid line, which was radial versus femoral female patients. So significant, even derived a greater benefit numerically than male counterparts. So this is definitely a true statement. In Matrix, the benefit of transradial intervention in ACS patients in terms of reduced vascular access complications was only seen when compared to patients receiving transfemoral procedures without vascular closure devices. So can this benefit be negated by vascular closure devices, is what the question is asking. So is the benefit only in those who didn't get a VCD? Raise your hand if that's true. False. Oh, God, you guys are pretty solid here. Okay. Yeah, so vascular closure devices we've known for a long time don't reduce access complications. They reduce time to ambulation and time to hospital discharge. And this was a sub-study of Matrix which showed this. Again, complicated central illustration here. Green is radial, blue and red are with or without VCD femoral, and you can see really no differences there other than between transradial and all transfemoral, regardless of VCD. So this is a false statement. In ACS patients, cumulative randomized data suggests a significant reduction in mortality at the cost of a slightly higher incidence of CVA when transradial access is utilized compared with transfemoral access. So you save lives, but you have a slightly increased risk of stroke when you go TR. Is that a true statement, A? Anyone? Or is that false? So some falses and not a lot of trues. Yeah, I mean, that there have been all different types of arguments against using a transradial, like somehow that's exposing patients. And most of this risk, anyone who's been in the lab for any amount of time knows it's kind of technical more than anything. If you're not providing adequate anticoagulation, not tracking over wires, spending excessive time in the aorta without identifying the proper catheter, not, having proper manifold hygiene, all those things put patients at risk for stroke, less so than the access site. This was a meta-analysis that came out with the publication of the Matrix trial a couple of years ago. Really pretty powerful 20,000 patient meta-analysis. There have been even larger ones since. I haven't changed the slide, but they say the same thing, that you can see there was a significant reduction in death. These are randomized patients in this meta-analysis, 0.72, 28% relative reduction. And the stroke on the bottom there is completely overlapping unity, so no increased risk of stroke. Of course, there's patient selection, and you got to make good decisions for individual patients, but that's not a reason to not go transradial. So how is all this data translated into the guidelines? And this is where it gets, every time I give this talk, I still can't believe it hasn't changed, but it hasn't. You'll see the older year dates there. So this is ACC-AHA guidelines for just regular old PCI, elective PCI. Is it one level? I'll ask you guys to answer here because this is pretty relevant. Using a transradial access, is it, so you guys know the classes, the recommendations are 1, 2A, 2B, and 3, 1 being definite, 3 being definite harm, and 2 and A and B being likely do it or likely don't do it. And the level of evidence is how much data there is to support it. So again, I think most of you guys know that. So is TR for elective PCI a 1A recommendation, a 2A level evidence, or I'll read them all, 2A level of evidence A, 2A level of evidence B, or it's not specified? Who thinks A? Who thinks B? Okay. Who thinks C? 2A, but level of evidence B? A couple people, and not specified. Maybe no one. So it's actually 2A. So the evidence is very strong. It's level of evidence A, but it's just, the use of radial arteries can be useful to decrease access site complications. I mean, I don't know how soft of a statement you can make for the reams of data that support reduction in at least vascular complications. But anyways, they haven't sought fit to update those yet. What about for STEMI, ACC-AHA STEMI? Is it not mentioned at all? Is it 2A with a level of evidence A, 2B, LOE of A, or should be considered when feasible, in quotes, like the quote in the text? So A, not mentioned, 2A, level of evidence A, couple people, 2B, level of evidence A, should be considered. Well, it's never going to be 2B. If the level of evidence is A, the evidence suggests that you should do it, so it's unlikely that one. It's actually just written in the text. So amazingly, it's not mentioned as a recommendation. And this is a 400-page document that really talks about even like how fast the ambulance should drive or something like that. It's really goes into every little detail, and it just says should be used when feasible. Again, 2013 preceding this trial, but nonetheless, there have been several focused updates. One describing the use of multi-vessel PCI with STEMI, as you know, one describing the use of thrombectomy devices, and yet there has been no adjustment here. What about for ACS patients? I'm sorry, this is 1AA, 2AA, 2BB, or not mentioned at all. I think we're getting the gist here that it's not mentioned at all in this, which is remarkable for ACS. 2015 ESC guidelines, on the other hand, for ACS PCI. I'm just going to jump ahead in the interest of time too. Level of evidence, recommendation 1, level of evidence A, the strongest possible recommendation in experienced centers, which is exactly what the data shows, right? So updates are certainly sorely needed in the American guidelines. What about the magnitude here? So a significant absolute reduction in in-hospital mortality in STEMI patients is derived from all the following except TPA versus strepto, probably before you guys were even born, primary PCI versus lytics, door to balloon less than 60 versus more than 20, or TR versus TF, or all result in significant decreased mortality. So I think you know this. This is Gusto, 2+ decades now, 1.5% absolute reduction just going from TPA, from strepto to TPA. Primary PCI obviously became standard of care, 2% absolute reduction in MI. Pool data. Time is muscle kind of phenomenon here, less than 60 versus 120 at about a 1.5% reduction. This is in tabular form, the mortality, absolute reductions in mortality of these interventions. And you can see that radial versus femoral, the mortality reduction is 2.7 versus 4.7. Here's the comparative absolute reduction. So paradigm shifting, but yet not even in our guidelines. How about this? The most likely to benefit from transradial access are most likely to receive it. True or false? Yeah, false. I think everyone knows this paradox. We have ways of assessing those that are most likely to benefit. Those are most likely to bleed with the transfemoral procedure. So this is one scoring system, the type of presentation, age, gender, CKD status, etc. Yet this paradox still exists, where this is tertiles of femoral bleeding risk, low, medium, and high. And the black bars are femoral use. So as the tertiles increase, with high being towards the right, the femoral use actually increases, paradoxically. And on the right panel, it's for ACS and stable patients, so for both types of patients. So this is false. It's a real problem because you're mitigating your benefit of this strategy. TR versus TF has been shown to have higher Mace rates in which of the following complex subsets? So is there a reason for this? Is it that the patients that are higher risk to bleed also have worse efficacy outcomes, Mace outcomes? So post-CABG, left main, CTO, shock, heavy calcification, bifurcation, PCI. Do these have higher rates of Mace when we do TR, or is it none of them? Well, there's data on this. So the first and only randomized trial for a while was the Radial CABG, which did show that 130 patients, TR versus TF in post-CABG angiography, they showed more contrast procedure and fluoroscopy with TR, but it was a small sample. Fellows were allowed, no offense, to practice for the first 3 minutes. I'm not sure I would have been that patient. And the CABG anatomy was known more in the transfemoral group, so kind of not really that strong of evidence. There's been a subsequent randomized trial, the L Records trial, which really had in Greece a similar size, but a little bit more strict exclusions, and that really showed no difference in fluoroscopy, procedure success, or contrast, TR versus TF. This is for CABG patients. So no real data there. This is a meta-analysis, one RCT, which was the Radial CABG and 8 non-RCTs, 2,800 patients. Again, TR versus TF for CABG angiography. Complicated slides here, just really no difference in procedure time or fluoro time between the two, procedure failure rate or contrast use. And in the bottom panel, there was less access site complications, as you can see, at the expense of higher rates of access crossover. So that did occur. There was higher crossover with radial to femoral and CABG patients, but you were still deriving access site complication reduction. This is NCDR, big data, 10 years, 1.3 million CABG patients getting cath or PCI. And they showed statistical reductions in mortality, bleeding, vascular complications, and actually higher procedural success. Of course, this is selected. This is not randomized data, but it's still relevant. Utilization went from 1.4 to 18% over this 10-year span. TRA had shorter fluoro times if you were just doing PCA. If you did an ad hoc, a cath only, or a cath plus a PCI, it was longer. And those that were more likely to use it in non-CABG patients used it more in CABG patients, unsurprisingly. What about left main? This is our own, one of our graduating fellows, Sunny Goel, published this. Left main PCI radial versus femoral meta-analysis, 17,000 patients. Again, less vascular complications, no change in procedure success, time, contrast, or fluoroscopy. Again, it's all observational. Are there less sick patients getting this? It's possible, of course. CTO, the story is the same or similar. This is the Recharge Registry in Europe, 12,000 CTOs, 17 centers. They looked at fully TR procedures versus any TF. So if you had a radial and femoral dual access, it would be in the femoral group. What did they show here? That the procedural success was equal regardless of lesion complexity. So these are by JCTO scores, your Japanese CTO scores, 0, 1, 2, 3, or greater than 3. There was a trend towards less procedural success when they looked at the propensity analysis of the lowest quintile, so those that were had the least propensity to get a TR procedure had numerically lower success. So it's possible and likely actually, but still overall near equivalent procedural success. This is from the Progress CTO registry. I'm going to go a little faster. I was going slow first. 3,800 CTOs analyzed in US and Europe as well, similar analysis. There was statistically significantly less TR access for the higher scores. So this clearly demonstrated a difference in the tougher CTOs, but the procedural success was equal regardless of how complex the CTO. So even in the JCTO 4 in the progress CTO4 groups, there were equal success. What about shock? This is post-hoc from culprit shock, 600 patients. Again, this was not an access trial, so 17% TR, 80% TF. And there were trends towards statistically significant reductions in 30-day outcomes. It was operator choice for that, so there could still be a bias. It normalized at 1 year, but it was definitely feasible. This is really an amazing trial. It just got published, months ago, which is a color trial, which really looked at this. It was kind of large bore access to incorporate all the things we just discussed: CTO, left main, calcification, bifurcation, planned PCI patients, but it was prospective randomized, 400 patients. And this is their central illustration: significantly less bleeding, vascular complication, equal procedural success, and crossover rates. The distribution's up there, so 58% CTOs, heavy calcification, bifurcation. It's a real complex subset, all getting 7 French procedures in a randomized way, so really taking out a lot of that bias. So none of these has really been shown to have higher MACE rates. What are predictors of unsuccessful PCI from the transradial route? We've known this for a long time. Old patients, prior CABG, we saw the crossover rate, and short height. This just shows height kind of across a more continuous spectrum, really less than 5'4", much higher rates. This is another score. Some people have used female sex bypass and shock, kind of a scoring system. You can see an asymptotic. So you have to do a patient selection. Are you going to use LV support? Are there other parts of this procedure that would make you go femorally? But remember, they all benefit from this. So obesity is the only one. Proven strategies to reduce radial artery occlusion, or TR, smaller sheath, therapeutic anticoagulation, patent hemostasis, ipsilateral ulnar, or post-procedure enox, avoidance of repeated access. The answer here is going to be E. We'll go through the data. So sheath size we know relates to RAO. Higher sheaths size have much more higher rates of RAO. Newer technology has improved this. Inner lumen diameter preservation with the slender sheaths, so 5 French outer, 6 French inners. Anticoagulation, half is not enough. We know for a long time, Dr. Pencholi has done a lot of work here. Full anticoagulation is required to reduce this. If someone's on Coumadin, that does not equate to adequate heparinization, so they need full heparinization. Patent hemostasis, so we want compression hemostasis without cessation of flow. So when this is a trial that looked at, Group A, which was just above MAP, versus Group B, which was above the systolic, much higher rates when you had occlusive pressure. How do we know? Reverse Barbeau test, most know this. You have the TR band on, you compress the ulnar. If the radial is still patent, then you will have a waveform distally. This shows, again, patent hemostasis. This is ipsilateral ulnar. So this is a randomized trial where they did ipsilateral ulnar compression during the patent hemostasis for 1 hour, and that group did even better than patent hemostasis only. Lower caliber vessels by IVUS with repeated procedures, so we know that does cause RAO. Do you want me to end on time, or do you want me to? Okay, I'll do it just a couple more. Let's jump through here. This is radiation exposure and volume. Certainly there's a relationship that's relevant. This was seen in the Matrix trial. There was more thorax radiation in the radial group. It is a function. It is decreasing over time, so the difference in radiation fluoroscopy times is narrowed over the past decades, probably related to technique. Best practices: avoid fluoring the arm, fluorosave. Low radiation femoral operators are low radiation radial operators, so it's really more radiation hygiene. The learning curve is about 50 cases. I'll jump forward to their right radial has more radiation exposure. There's randomized trials to show that left radial. This is also seen in the Matrix trial. Some meta-analysis that show that at the expense of comfort. So radial, right radial, left radial would have worse comfort but less radiation. Acute kidney injury, higher in the transfemoral group in Matrix, so was an important finding. This shows statistically higher rates of AKI, 25% increase or 0.5 absolute, mostly in the sick patients. So these are not reasons to avoid radial. ACS patients with low GFRs, older than 75, high Killip class, high Moran score for CIN, those patients need radial even more. Lastly, length of stay is significantly reduced. There's tons of data on this. BCIS, this is 400,000 patients, saving about $500 to $1,000 per procedure. Lastly, patients prefer this. Quality of life is much reduced with transfemoral relative to transradial. In the Radial trial, I love this slide, and I'll finish with this. They asked patients, they were randomized, we talk about complication rates and Mace and things like that. 50% of people said they would want the same access, meaning 50% wouldn't. Obviously, 50% didn't have complications. They had a bad experience versus 90% in the radial group. So I know you guys are already leaning this way, but it's important. So on that note, I'll stop. Ask my final question, which is, I'll still do it, I guess. If you had a STEMI and it wasn't shock, would you want radial, femoral, radial? You can raise your hands. Anyone want femoral? I should ask it the opposite way. Sherman, you want femoral? Anyways, thanks. Good luck. Sorry we went over there. There's not a lot of time for questions.